Good morning, everyone. My name is Niambi Cooper, and I'm the director for ONEgeneration Senior Enrichment Center here in Reseda. We are so excited today to have Dr. Gary give us a presentation on varicose veins and a lot of more exciting information. So without further ado, from UCLA, I have Dr. Gary, and I'm going to pass it over to you.
Fantastic. Let me share my screen. Let's see how this goes here. Can you guys see the PowerPoint that's on my screen?
We can, Doctor.
All right, fantastic. It's nice to meet everybody. My name is Gary Say. I'm one of the interventional radiologists at UCLA and the co-director for North Hollywood, my counterpart being Dr. Howe, which I think he gave a talk on the artery side of things a few weeks back. I apologize that I had to reschedule my talk because I had a case run long. Okay, so no financial disclosures at all. So I think we'll just touch base on these 6 different things here. One, just an introduction into venous insufficiency. I'll explain what that means and the definition. Epidemiology, who it affects and who's involved, who's most at risk. What risk factors contribute to this? The pathophysiology, how does venous insufficiency occur? And then diagnosis, how do we make the diagnosis? And then what we can do to treat and fix these problems. So what exactly is, let's move this. What exactly is chronic venous insufficiency? It's a condition when the veins in your legs aren't working well. So essentially these valves in the veins, they help to push the blood back up from your feet towards your heart. When those valves don't work well, it makes it difficult for that blood to return to the heart. So chronic venous insufficiency, or CVI, causes blood to pool and collect in these veins, and that pooling is called stasis. So a lot of our patients that I see that come in with these problems, they come in with swelling in their legs. You know, when your legs get real puffy and you push on them and you can make these little dents in them because of the fluid in it, achiness, itching. Patients complain of heaviness in their legs as well as cramping, particularly if they've been sitting all day. And then skin changes that we do see with chronic venous insufficiency include browning discoloration, most often near the ankle and the lower calf. You can see varicose veins, which are those sort of dilated veins that you sometimes see around your calves or thighs. Spider veins, and again, I'll show all pictures of these so that we have a better idea of this, but then spider veins are those little reticular, like they look like spider webs in your skin. They're usually blue or red. Whitening of the skin, patients can complain of pain, as well as ulceration. So ulceration is sort of the condition that we want to avoid, but is often a result of chronic venous insufficiency. So what about the epidemiology? Who does it affect? What are the risk factors for CVI? Varicose veins, we see anywhere from 5 to 30% in adults. Women are more likely to have it, 3 times more likely than men. There's this vein study that looked at 1,500 patients with ultrasounds that showed reflux, and it showed that a lot of people have reflux. So you may not be symptomatic, but a lot of people have reflux. So 9% of men and 6% of women. Venous stasis ulcers, which again is the condition that we'd like to avoid, because once we get there, it becomes more and more difficult to treat. Can affect up to 500,000 people. And it does contribute to some emissions. CVI can cause, 92 for every 100,000 emissions is due to some sort of chronic venous insufficiency disorder. The prevalence of varicose veins is higher in developed industrial countries. We're not really sure where that comes from, but it certainly is. And there are various risk factors, including age. The older you are, the more likely you can have it. Sex, females more likely than males. A family history, people that are overweight or obese can certainly have higher pressure, and so the venous blood can pool. Pregnancy, of course, is a risk factor because the uterus, when it's gravid, pushes on the veins in the pelvis that causes backflow into the legs. Phlebitis, which is essentially an inflammation of the vein, often predisposes to CVI as well as prior leg injury. And then there is a suggestion that prolonged standing and sitting posture at work can contribute to CVI. The more serious consequences, like I mentioned earlier, venous ulcers have an estimated prevalence of about 0.3% in the US. we can see active or healed ulcers. So with adequate wound care and treatment, like we'll discuss, you can heal these ulcers, and that is reported about 1% of the adult population. And these are just some more numbers. 20% of those that have CVI ultimately develop venous ulcers, so we want to try to avoid that. Like I said, the overall prognosis of venous ulcers is poor because once you get to that point, you have delayed healing, and recurrent ulceration is very common. There is a socioeconomic impact of venous ulceration because it impairs people's ability to go about their daily lives, to go to work and to socially interact. So it does have impacts on quality of life as well as finances. This is just a schematic of what I was discussing. Essentially, a normal vein has these valves. When you walk and your calf muscles squeeze, blood goes from the feet up towards the heart, and the valves prevent blood from coming back. When the valves don't work as well, as you can see, it no longer becomes one way. It goes back and forth, back and forth. And so when you have this damaged valve, blood can, instead of going and getting squeezed back towards the heart, can pool in your feet, calves and thighs. And so that's what those symptoms originate from. The initial swelling, the reticular veins, then the varicose veins, and then progression into ulceration. So I'm sorry this didn't come out so well, but that's essentially what I was explaining. The calf muscles in red squeeze the blood towards the heart, and the valves prevent the blood from coming back. When the valves aren't working so well, blood will just kind of pull back as opposed to going up towards the heart. It pools in the legs. Not to get into particular detail, but there's a deep and a superficial system. When we talk about veins, the deep veins, that's when you hear about DVT or deep vein thrombosis. That's a different thing, but does contribute to venous reflux. What we are talking about more about the ulceration and reticular veins, varicose veins, is the superficial system. So if you look at this picture, we've got skin here on the right, the superficial system, and the deep system on the left. There are perforators that connect, so they're all connected. But today we're really talking about venous reflux in the setting of the superficial system. But reflux in the deep, in the perforator, or in the superficial can all contribute to those symptoms that we mentioned in the beginning: the cramping, the heaviness, the itching, the swelling, and the pain, and then ultimately the ulcers that may form. This is just the natural progression, like we mentioned earlier. If you can see here, in the origin, go back, the veins, if there's some damage to the vein, whether it's you had a clot or vein capacity, I mean, patients with heart failure or patients that have been standing for a long time, or pregnancy that are blocking upstream, or again, obesity, and occupation, like we said, standing a lot or sitting a lot, those valves become damaged. And because of that, you have abnormal venous return, meaning the blood no longer goes back towards the heart. Like I mentioned earlier, the signs that we see is this edema, which is swelling, capillary leakage, which is the discoloration, the redness, and I'll show some pictures of that, the redness and sort of a dark browning of the ankles or the calf, that goes along with skin changes and ankle flare. And on the background of that causes inflammation, which destroys tissue, prevents healing, and that's ultimately how that leads to pain, discomfort, heaviness, and then the ulceration and ulcer recurrence. So that's sort of the disease process of how this works. So how do we make the diagnosis? Physical exam is clearly important. I routinely have my patients take their pants off, of course. We cover their pelvis, and we look everywhere on both sides of the legs. History, like I mentioned, some of those risk factors, the more that I hear about those risk factors, multiple pregnancies, obesity, differences in occupation in the past, those can clue you in that the symptoms are actually due to venous insufficiency and not due to something else. And we always confirm with ultrasound. So these are some pictures of the progression. So there's this, whenever I see my patients, I categorize them into the SEEP, which is C for clinical, E for etiology, meaning what's the cause, A for anatomy, where it is, P is pathophysiology, was it because of you had a deep clot before, was it because of pregnancy, other things like that. And as you can see, as you go up the scale number, it gets worse. So C1 is very mild, just these little spider veins, we call them reticular veins. They're just sort of, you know, looks like tiny little roots or branching on the skin. A lot of people have them, quite common. And then as the venous reflux gets worse, we start to get more varicose veins, which are the larger dilated veins that you can see on your calves or thighs. And then you start having edema, meaning you're starting to have swelling. This person not only has swelling, but also has that discoloration. Again, that's because of the venous pooling. Those red blood cells are now they're getting squished, if you will, into the skin and causing that discoloration. And then ultimately you start progressing to skin damage. It becomes more and more red. Edema doesn't allow you to heal. So if you have a little trauma to the skin, it won't heal as well. We here have a healed ulcer. It's red, that's healed, but this is an active open ulcer. Again, this is a progression of venous, chronic venous insufficiency. Again, we make the diagnosis with ultrasound. We look at how long there's a reflux time numbers, and we look at the diameter of the veins. Those clue us into venous reflux as the cause of symptoms of heaviness, itching, aching, and ulcers of the leg. Because there's other things that can cause those symptoms, but the history, the physical exam, and the ultrasound ultimately provide all the information for us to make the diagnosis of chronic venous insufficiency. These are just subcategories, just to show some more pictures. Again, when you have an ankle flare, that's essentially the capillaries, which are the small, tiny blood vessels in the feet. They start getting dilated, and so you can start to see them through the skin, which a lot of people have. But again, this is like the very early signs of venous insufficiency. Sometimes when these veins get dilated, they can also become itchy, which is another sign of CVI. Like we mentioned, varicose veins, these aren't even that bad, to be honest, but essentially they get more and more stretched, and the wall gets fibrosed or scarred down because of all the volume of blood that it's pooling, and then they sort of bulge out, and those are the ones that we can see in the skin. Edema, that's a lot of people have this as well. That's when your lower extremities get really puffy, and that again is a little different, but essentially the fluid within the interstitium or within the skin starts to get backed up, and that's what causes edema, or the swelling that a lot of our patients have in their legs. Varicose edema, essentially it's similar to edema, but the skin becomes more flaky or dry, and it can cause more itching, and is red and itchy, sort of how we saw in this photo. Okay, so that's varicose edema. And lipodermatosclerosis, once we start having more and more inflammation in the legs because of this prolonged swelling and because of the pooling of blood, the skin starts to become a dark red, brownish color, and it becomes firm because it becomes more and more fibrotic or scarred down. And hemosiderin staining, we saw earlier, that's, like I said, when red blood cells leak from the capillaries, they stain that tissue a brown or a rusty color. We often see it on the medial ankle. So why do we care about venous leg ulcer patients? Like we said, 1 million people are affected in the US. 70 to 90% of ulcers that we see in our patients in the lower extremities are due to venous reflux and venous insufficiency. It contributes to 20% of all wounds seen in wound care clinics. Those are venous ulcers, and up to almost $15 billion is spent annually to treat these ulcers. So it is important that we try to tackle these earlier, and we try to manage our patients well to prevent those complications. This is just to show you that in the guidelines, in the context of venous reflux, that they're all high grades, 1 and 2s, i.e., duplex is going to be the first line evaluation for patients that we see with the venous leg ulcer or other symptoms suggestive of reflux. We recommend ablation to prevent recurrence of ulcers, and that's 1B, meaning there's high quality evidence to suggest that that is beneficial to patients, and it's a high level evidence in addition to standard compression stockings. So we always recommend compression stockings to start, and once we start going down the route that that's not improving, particularly in patients with ulcers, then ablation will help to prevent the ulcer recurrence. Ablations will also help to heal ulcers. So if a patient already has an active ulcer, we find the incompetent superficial vein feeding that ulcer, and we do that with ultrasound as well. And then we recommend ablation. So essentially scarring down that refluxing vein. We also know that ablation helps to prevent ulceration in prevent ulceration as well as ulcer recurrence. This last category is slightly different. We still offer this as well. This is called venous angioplasty and stent recanalization. That's with patients that have deep venous reflux or deep venous thrombosis or clot. Everything before I was mentioning was the superficial system, but this is a little bit less common and usually occurs in patients that have had prior stents or have had prior clots in the deep veins. So thermal ablation, which is, we certainly offer that at North Hollywood with laser. It accounts for 97% of all CVI procedures. There are others other modalities that exist, including surgical stripping, which not a lot of people do as much anymore. There are mechanical, chemical, sclero. We actually offer all of these at UCLA, but the workhorse, which we offer, are RFA, radiofrequency ablation, and laser ablation. So, and I'll explain briefly what those are. So what are the treatment options again for patients with CVI? We always recommend compression stockings, which a lot of our patients come to us already have. Venous ablation would usually be the first step. After we do the venous ablation, we do phlebectomy, which is we cut out using a small, tiny needle. We cut out the dilated varicose veins, the ones that are causing pain or the ones that are itching or that have swelled up. We can always do touch-up with sclerotherapy. That's injecting a little chemical irritant into smaller veins that are next to the big veins. And again, if the patient already has an ulcer or is at risk for ulcers, we highly recommend wound care and can facilitate that. This came out a little blurry. So again, the two main workhorses are laser and radiofrequency ablation. It's essentially thermal based. So we're putting a little probe, as you can see in this picture, like this little, it's literally smaller than a pencil. We place it in the vein, anywhere from the calf up to the groin. And from there, we turn on the energy. With RF, it's radiofrequency. With laser, it's laser, it depends on the wavelength. And it delivers energy to the inside of the wall of the vein and essentially damages the inside of the vein as we're pulling the probe back. So we usually, there's two veins that we primarily tackle. There's many others, but the main ones are the great saphenous vein and the small saphenous vein. So one is from the medial ankle up to the medial thigh. The other one is from behind the ankle up to almost behind the knee. And we put a little probe in there and we drag it back. As you can see, if you can picture these two purple lines as the vein, this is the laser within it. It gets slowly pulled back and it's releasing energy or heat onto the walls of the vein, and it causes it to get damaged and scar down. And the whole point of it to scar down is so that vein no longer can reflux. Blood can no longer pool in that vein and cause damage to the skin in the calves and the ankles, causing ulcers or causing the darkening of the skin or the scarring of the skin. So how do we do it? We bring you in first, after you've had the ultrasound, of course, and we mark your veins using ultrasound so we know exactly where we're going to go. We don't usually give any medication in an IV for this. So it's in and out. You come in the morning, we mark your veins, we numb up the entire leg. So after we place the probe, we numb all around the vein that we're in so that it's completely separated from the skin above and the muscle and fat below it. And then we pull back that fiber, like I mentioned, we slowly pull it back, and it helps to scar down that vein. In very, very rare cases, in patients that have high anxiety and really, really threshold for pain, we can use moderate sedation. That's pain medication and an anxiolytic and an IV, kind of like a Xanax, to help relax the patient for the procedure. But I'd say 97% of all of our cases are local anesthetic only. Everything is sterile and surgically prepped, of course. Door to door, it takes about 30 minutes, probably an hour because we have to clean up the skin, but usually the procedure itself is only 30 minutes. For the GSV, again, that's the one from the medial ankle to the medial thigh. We usually just have the patient lay on their back and frog leg the leg, meaning sort of open up the knee. For the small saphenous vein, that's the one from behind the ankle to behind the knee. The patient's usually on their stomach. This is just an example. As you can see, this is the vein in black. This linear white line, that's the probe. And we usually pull that back. And as you can see here, This is just the needle going into the vein, how we access the vein. But once we're in the vein, I can see the probe. All we do is slowly drag this white linear line back. And so that's why it's a pretty safe and quick procedure, and everything is done under ultrasound. What are the complications? They're pretty rare. Most of them are self-limited. Bruising is common and usually lasts only about 1 to 2 weeks and resolves quickly. Some patients complain of a pulling sensation. If you think about the vein that goes from your ankle to your medial thigh, it's once it scars down, it's almost like a rope. It becomes, very tight. And so some patients complain of a little bit of pulling sensation, but that usually resolves, over a few weeks by itself. Thrombophlebitis, that's when other veins adjacent to the vein that I just scarred down, the vein that I treated, they get inflamed. Usually just hot compresses resolves that. So it's pretty self-limited. Paresthesias, which is sort of a numbness and tingling, that happens infrequently, usually around near the knee, but also generally self-resolves. And very uncommonly, patients can get a DVT, which is what we don't want. That's when you form a clot in the deep system. Remember how I said there's a deep and a superficial? The superficial is the one that we treat. The deep ones we try to avoid. But very rarely the deep veins get irritated by that thermal energy, by the radio frequency of the laser, and it forms a clot in there. If that happens, we have to put the patient on blood thinners and get follow-up ultrasounds. But again, that's uncommon, but is one of the reported complications. Post-operatively, after the procedure, again, like I said, it's only 30 minutes to an hour. It's an outpatient procedure. We wrap our patients' legs in stockings or some sort of ACE bandage. We recommend that they wear stockings for the following 2 weeks, if not longer. But the patient can resume normal activities. Try to avoid a vigorous exercise to begin with, but after 2 weeks, the patient can do whatever they like. And I normally do a follow-up ultrasound within a week. And that's more to confirm that the veins scarred down. In uncommon cases, they don't. I can bring them back and do a little bit of touch-up, as well as to make sure that there's no clots in the deep vein system. So in conclusion, chronic venous disease certainly affects many people, like we discussed in the epidemiology section. It does affect patients' quality of life. We certainly offer all these treatments here: venous ablation, phlebectomy, which is surgically removing the vein, sclerotherapy, which is irritating the smaller veins with a chemical irritant, referrals for wound care. And again, all of these procedures are done as an outpatient and usually with just local only. So with that, thank you very much. I'm open for any questions if anybody has anything that they want to ask.
Thank you, Dr. Gary. Does anyone have any questions?